Hello and welcome everyone to this session. We're very excited to have Martha Kelso, who is the Chief Executive Officer of Wound Care Plus, with us here today. She'll be speaking about her retrospective study in a presentation titled Imaging Bacterial Load in Complex Wound Patients, Outcomes Analysis of Healing, Infections, and Life-Threatening Complications. Martha, we're so happy you could be here with us today.
Thank you for the introduction. I appreciate that. Let's get started. We're going to start with some key points. I believe that skilled nursing facilities and the long-term care settings have high rates of wounds and wound-related infections. I've seen this in my clinical practice for the last 20 to 30 years. We know there's higher antibiotic prescribing rates there and a lower 12-week wound healing rate than the national average. Why is that? Comorbid medical conditions, polypharmacy. The ICD-10 list on that face sheet is a litany. It's a huge, long list because we are dealing with the aged and the sick. We know that earlier detection of bacterial load and other risk factors is critical for infection prevention in this high-risk patient population. So this session, we're going to describe results of our retrospective chart review of wound outcomes and antibiotic prescribing rates in skilled nursing and long-term care facilities. We're going to compare that to pre-MolecuLight adoption and post-MolecuLight adoption using our point-of-care fluorescence imaging of bacterial load and its locations. Let's start with the impact of aging on wound healing. We know that there is not a lot of real-world evidence out there when it comes to clinical studies, particularly in the long-term care and skilled nursing sector. Yet, paradoxically, this is the most vulnerable population out there. These are clinically challenging population, both medically and cognitively. This is where we have cognitive impairment, refusal for some aspects of care, dementia population, sometimes end of life, and therefore this medically challenging and cognitively challenging population greatly benefits from advancements in medicine and biotechnology. Food for thought about our aging population. We know, based on clinical research and studies, that immune systems in our aging population become slower to respond than walkie-talkie younger generation, the mobile generation that maybe goes to an advanced wound clinic instead of being at the skilled nursing or long-term care building. We also know that our aging has an immune system that's may develop autoimmune disorders and become resistant to helping fight infection. The body is slower to heal, and there's fewer immune cells and immune modulators in the body to bring about healing or express signs and symptoms of infection. The immune system in our aged and elderly population also has a defect when it comes to detecting and correcting cell defects and declines. We know that it just doesn't respond like it does when we're younger. So, impact of aging on wound healing. Skin infections are the third most common type of infection in seniors. Infectious diseases are a common cause of increased morbidity and mortality in elderly patients. We see oftentimes when we're sending them out to the hospital, they're admitted for sepsis, even though they may not have had symptoms of sepsis until well into the disease process or the infection process. That's because in the elderly, that fever response is often blunted, even in the presence of bacteremia or sepsis. We also know that pressure ulcer infections are more frequent in patients living in nursing homes. And 1/3 of all deaths in seniors over the age of 65 are from infectious diseases. Many elderly present with non-specific clinical symptoms and functional decline, which makes an accurate diagnosis difficult and may lead to life-threatening delay in diagnosis and therapy. All big challenges. That brings us to the objectives of our study. We know that incorporating fluorescence imaging technology like MolecuLight to the everyday care of long-term care and skilled nursing had a major impact on clients under our care. So we looked at heal rates measured at the 12-week mark. We looked at wound area reduction, antibiotic usage both topically and systemically, number of debridements required or performed, use of cellular tissue-based products, otherwise known as synthetic skin grafts, requirements for PCR microbiology or tissue biopsy sample cultures, and those can be very expensive as well. We looked at rate of wound infection and rate of complications from a wound infection. And then we looked at how does MolecuLight impact this information. MolecuLight, of course, is a portable point of care, non-invasive wound imaging device that helps us detect bacterial burden in wounds real time. We're not waiting for days on end for that microbiology report to come back and the culture and sensitivity to come back to determine if true clinical infection or elevated bacterial burden exists. We can perform digital wound area measurement with this device without contrast agents, and there's no patient contact, which means no pain, no contamination, and it's very, very simple to utilize and adopt into your clinical practice. We do have to have a darkened room, but that's as far as it goes. No pain. For fluorescence imaging, it is precise wavelengths of safe violet light that interacts with wound tissue and bacteria. It can detect bacterial loads of 10 to the 4th power, which is considered pathogenic, obviously can cause true infections when it's pathogenic. Bacterial loads fluoresce with specific colors depending on the pathogen encountered. For example, red fluorescence is indicative of a porphyrin-producing bacteria, where cyan is indicative of Pseudomonas, that bright green halo. The device can filter out other colors to avoid confusion, and together with a clinical assessment for signs and symptoms of infection or suspicion of infection, it works very, very well. Let's move on to our study. Real-world evidence of improved outcomes in Medicare beneficiaries, particularly in the long-term care and skilled nursing population. This is a retrospective analysis of our electronic medical record data. We pulled 193 wounds from 113 Medicare-covered patients, utilizing 17 providers across long-term care and skilled nursing facilities in 4 states. We had a standard of care cohort, which was a lot of it pre-COVID. They were admitted between January 2019 to March of 2020. That resulted in about 52 patients with 89 wounds and performed debridement, but no bacterial fluorescence or MolecuLight. Then our MolecuLight cohort group was admitted between February 2021 through March 2022. So really after the intense part of the pandemic was over. Resulted in about 61 patients with 104 wounds, and we performed MolecuLight procedure on those patients. The wound types were anything from diabetic ulcers to pressure ulcers and even mixed etiology ulcers that had pressure as a contributing factor. They had to have been under our care for at least 4 weeks of treatment and up to 3 wounds per patient. So if there was more than 3 wounds that were eligible on that particular patient or resident, then we randomly selected 3 of those wounds. On average, in our database, about 2.54 wounds per patient as a general rule of thumb for all of our residents under our care. And so it's not unusual to see people with multiple wounds per visit. And so you can see we had a wide variety of patient age. We also had male and female, obviously polypharmacy, lots of comorbid medical conditions, and all different wound types: diabetic, pressure, chronic. We had full thickness, partial thickness, and even unstageable wounds. So characteristics of a lot of different different things and making sure that we were seeing that nice wide variety. The real wound evidence of improved outcomes with our Medicare beneficiaries showed some pretty interesting data. So we can see standard of care is the gray bar, MolecuLight is then the blue bar. Look at the difference in wound heal rates once we implemented MolecuLight. That is a staggering difference. Also, the average duration of healing versus those that fully healed. So 17.6 weeks in our standard of care versus 12.2 weeks to heal after implementing MolecuLight. What does that mean? It means that 60% more wounds healed at 12 weeks. It also means that we had a 36% faster heal rate in the MolecuLight study cohort. Those are fantastic numbers, particularly in the long-term care arena. Also, real wound evidence, our wound healing percent key points, we had a divergence that started about 4 weeks. By 20 weeks, the standard of care still had not caught up to the MolecuLight arm at 12 weeks. That's extremely impressive. Also, after implementing MolecuLight, our percent of patients prescribed systemic antibiotics went down by at least 30%. Those are huge numbers. And we know in our senior population, systemic antibiotics are detrimental. It can cause serious side effects like confusion, C. diff colitis. Systemic antibiotics are not what we want to reach for if we don't have to in our elderly population. The percent of patients with severe wound complications also decreased by 82%. These are staggering numbers. And so that 82% of severe complications, we were looking for things like osteomyelitis, sepsis, cellulitis, gangrene. So to decrease those severe complications by 82% is a huge win for our elderly and aged population. The percent of PCR microbiology performed decreased by 40% once we implemented MolecuLight as our standard of care. Again, big numbers with big cost savings. So a quick summary of findings. The percent of wounds prescribed systemic antibiotics in our standard of care population was on average 47% of the time. Once we continued with standard of care and MolecuLight, it decreased to 33%. The percent of wounds healed at 12 weeks was 20% pre-MolecuLight. Post-MolecuLight, that number increased to 32% of the population. Our time to wound healing decreased dramatically, and our percent with severe wound complications also decreased dramatically. So some real-world case examples. This is a person that we had debrided. This wound had necrotic tissue in it. We debrided. This is an amazing debridement. We were able to do targeted, we were able to do an appropriate debridement and then fluoresce with MolecuLight. Once we fluoresced with MolecuLight, we could see a hidden abscess under the skin. Even though this debridement looks amazing, you can see there's no necrotic tissue left. Once we found that hidden abscess, we were able to do a targeted treatment, an actual incision and drainage, removing an abscess that was hidden very, very close to the rectum. Additionally, with MolecuLight, we are able to do targeted debridements, get accurate tissue samples so that we know where we need to be getting that infected tissue from versus potentially selecting a site that maybe has no bacteria in the wound bed. We can also confirm the need for intervention like debridement or antibiotics through the use of MolecuLight, real-time imaging at the bedside. Some take-home points. We know that antibiotic stewardship and antimicrobial stewardship is expected across the healthcare continuum. No more can we just prescribe antibiotics because we think a wound might be infected or we think the wound is acting infected. MolecuLight helps meet that call to action. Antibiotic surveillance is also one of those things that we are expected to do as prescribers and as wound clinicians and medical professionals. Understanding that maintaining whether or not someone needs an antibiotic with real-world evidence is imperative. Also, our quality assurance performance improvement process, MolecuLight helps meet that call to action. Understanding that MolecuLight allows us to see true quality before we're having to prescribe and possibly even eliminating antibiotics assists with our performance improvement. Additionally, in the real world setting for that long-term care skilled nursing population, this includes significant and lengthy comorbid medical conditions, lots of polypharmacy, and chronically stalled wounds. That makes this research even more compelling for this non-invasive handheld portable diagnostic tool. The impact we've had on our seniors, the elderly population, and that post-acute care sector is invaluable. Thank you for allowing me to present, and I'm ready to take your questions.
Martha, terrific presentation. Thank you so much. So for everyone listening, please, if you have questions, do put them in the chat box within this Zoom chat, and we will get to as many as we can. Something that I found very striking is how your data in the real world and in skilled nursing facility long-term care mirrors randomized control trial data, which is not often the case. You know, that you're able to reproduce those randomized control trial results in the real world scenario, especially in skilled nursing facility long-term care. So congratulations, Martha. That's
thank you. Yeah, our teams really love the device, and actually the comparison of our real world data to the RCTs actually speaks to the ease of use of the device. Obviously, during the pandemic, we've had a lot of challenges, like most healthcare entities, with staff turnover, having to retrain bedside nurses on how to do wound dressings and follow protocols, treatment protocols from our providers. And so the fact that comparing those two cohorts and then finding the amazing amount of data that we were able to produce in the real world setting just speaks to the device and what it really brings to the bedside.
Fantastic, thank you. Martha, so you've done this study specifically on the Medicare patient population. Can you explain why that choice was made?
Sure. When we first adopted the device, Medicare was the only payer that was covering it. I mean, we're talking 2.5, almost 3 years ago. So Medicare, Medicaid plans, private insurances hadn't really heard of the device yet or even had time to see the benefit. So when we went to go do the clinical research study, we had to look at the Medicare population because that's who was covering it. Now, fast forward 3 years, more and more payers are adopting this device as something that you saw the heal rates, and even saving that 5 weeks of heal time, that saves payers millions of dollars annually. So we're starting to see more and more payers adopt this modality.
And this study was done specifically on, well, it was diverse, diabetic foot ulcers, pressure ulcers, and some mixed etiology wounds. Would you use this on other wound types as well? I'm sure you had to do some narrowing for this particular study.
Yeah, we do. We use it literally on any wound that we think may be infected or have reason to suspect. We have a whole medical necessity criteria built in. So any of those wounds that meet the medical necessity criteria, our providers will use the MolecuLight device on, regardless of wound etiology. As we know, all wounds can be infected no matter what the etiology is. So.
Mm-hmm. And the case that you showed where you were able to uncover that abscess is really profound. Are you finding other, is that a regular occurrence? Is there other findings that you're discovering like this?
Yeah, it was one of those, wait a minute, what is happening here? As a matter of fact, I believe our clinicians actually called MolecuLight to review that photo specifically because where it was fluorescing, there was not a wound. So it was in the peri-wound tissue. So the clinician needed validation that what they were seeing was what they thought they were seeing. And so that whole, wait a minute, this device can also, in some cases, see subdermal bacteria that we cannot see with the naked eye. And so we have there's actually two different cases that I was brought into, that we had subdermal abscesses on a foot, and the foot would not, I mean, anytime you think about having to potentially cut body parts off, those amputations, and then realizing the device helped us identify hidden bacteria that was tunneling or sinus tract. Those are the potential for amputation that when you miss or cannot get them diagnosed quickly or timely, it's a huge risk for that patient, their body part, the practice, the whole nine. So what's the saving your bacon, I think is the term. But yes, we've had those over and over and over again now.
Okay. Martha, we've just had one last question that's come in from the audience. So they are asking whether there are any confounding factors in the wound bed for consideration when you're imaging. And I know we have a clinical applications team that does extensive training on that exact point. Anything you want to comment on there?
Yeah, one of the main things is getting trained over and over and over again on the device. So our clinicians are very proficient with the device now, but we still have them go through retraining, because obviously the more exposure you have to the device, the more things you pick up. So one of the things is understanding that it's the bright green fluorescence that shows cyan, where a more muted green fluorescence may actually be slough. And so the device, I know it's not an FDA indication, but as clinicians that are learning to interpret the different color spectrum, sometimes it's been able to help us identify slough versus ligament, bone, muscle, tendon in the wound bed too, outside of bacteria, even though it's not one of your indications. It's helped train our providers to have more of a trained eye. So
interesting.
Yeah.
Okay, before we wrap up, I do see a few more questions that have come in as expected about reimbursement, specifically in these sites of service. And so it is wonderful that there is reimbursement in these places of service, and that it is excluded from that consolidated billing in the skilled nursing facility setting. All right. Thank you so much. Oh, sorry. Go ahead, Martha.
I saw a question about Medicaid, and Medicaid's very much state by state. So my strong suggestion, if you want your Medicaid payers to cover this device, you have to reach out to them and ask, because they're not aware of it unless if the providers come forward and start petitioning. And they generally don't want to hear from manufacturers. They really want to hear from the providers, and the providers asking for coverage for this modality. So I'm just sharing that.
Good tip for the audience. And I know you've had success doing that with Medicare, with Medicaid for this very procedure.
Yep.
Okay, we need to wrap up, but there are additional sessions. There's another session coming up in a little while. Thank you all for attending here, and please be sure to visit us in the MolecuLight booth. Thanks so much, Martha.